Okay. When we follow through physiotherapy, we have our patients back in the clinic and they complain that they still have pain and it doesn't work. They improved a little bit, but they're far from getting back to the field. And we have to do something. We have the pressure from the clubs, from the federations, from the agents, from the player itself. After a while, we need to find some solution for them. So we know that conservative treatment, what we just saw, gives 80% success after 12 to 16 weeks, but you still have those 20% who went through the program and have not recovered, and you have to do something about it. In terms of inguinal pain, what we're talking about all day, this is the groin, is the area between the abdomen and the upper thigh on either side of the body. It's also used in the architecture, and it derived from the Old English grind, which is depression or abyss. But in Aspetar, we're not depressed about the groin because we have all the elements, anatomical elements from this area that make the name of our hospital. So in handball, you have groin pain. These are pretty strong guys with fantastic physical abilities. You have groin pain from direct contact, or from the strain after a shot, or after a stretch with the cocking phase before the shot, or changing directions, both offense and defense, but you can imagine the load on the adductors in full sprint. So we used to know that groin pain comes because of the imbalance between the abdominal and adductor muscles, and it was wrongly called athletic pubalgia. But what is the consequence? Is it the weakness of the posterior wall of the inguinal canal with the bulge compressing the genital branch of the genitofemoral nerve because of the imbalance of the muscles? Or is it the degenerative changes in the inguinal ligament causing pain at the pubic tubercle? Is it the entrapment of the inguinal nerves in this area? Is it the shearing forces causing inflammatory response at the symphysis? Is it adductor tendinopathy? Is it the periostitis of the pubic bone, or maybe all of the above? As far as we know now, there are only interpretations, no facts, as Nietzsche would say. So the origin of pain can be nociceptive, caused by noxious stimuli, like some inflammatory response, or it can be neurogenic, caused by nerve entrapment. The nerves in this area, the main nerves, are the genital branch of the genitofemoral nerve. That is, all nerves arise around the superior anterior iliac spine from the deep layers of the muscle coming front, and they're basically between the external oblique and the internal oblique muscle, so right under the external oblique aponeurosis. And the genital branch is positioned below the spermatic cord and lies on the transversalis fascia, on the posterior wall of the inguinal canal. So it can be compressed with the bulge from the posterior wall. The other significant nerve is the ilioinguinal nerve, which lies on top of the spermatic cord, usually right above the spermatic cord, and iliohypogastric nerve, which is positioned between the external oblique and internal oblique muscle, but a little more medial. So these are the nerves which are innervating this area, and there's a nice paper from Japan demonstrating this. Some colleagues from Japan did an assessment of patients coming to the clinic, and this is the pain distribution in the area. They contributed all of this to the inguinal nerves, but we're not so sure because this pain here, this 21% could be the iliopsoas pain or maybe hip pain. But you have a lot of patients with pain in the inguinal region or the proximal adductor region, as you can see. And the inguinal nerves are not like you see in the atlas. There's a big level of variation in their positions. So we need to take a medical history, careful. Since we're in handball, we can reduce it to 7 most important patients, like the 7 players. And you have the location of pain, duration, acute or insidious onset, timing of pain, so when do they get the pain, during sport, after warm-up. Did they stop sport? Because usually they would just modify the training, have some physiotherapy and say, I had treatment for 2 months and it didn't go away. Did they have proper physiotherapy or just rest? And did they improve over time? So we saw the clinical examination that we had to do, and you can see the number of elements that we are talking about here. So very complicated anatomy. And very important thing that is not in the periholmic paper is the invagination of the scrotal skin and palpation of the inguinal canal. So we heard before we thought that it was just these 3 entities. Now we have 5. In the conference, it is not October, I apologize, it's November, but we added 2 more, and today I'm talking about the inguinal related groin pain. So why we did this? We need to talk in the same language, like we call the players in different positions the name, so we know what is a wing player, what is a pivot, what is a 7 meter spot, what is a 9 meter line. This is the way we should address the groin also. So we need to do some imaging, which is not always conclusive, but we do an X-ray and we can see maybe the diastasis of the symphysis, but maybe there's hip impingement, apophysitis. In the kids, there's slipped capital femoral epiphysis. We can see some stress fractures, and we don't want to miss some tumors because there were a number of people treated for groin pain, and after 2 or 3 months, they would go through diagnostics and find out they have a bone tumor or something, and you don't want to be in that position. Usually, the X-ray will be normal, but just in case, do it. Especially if it's the case of inguinal-related groin pain, we need to do the ultrasound because it can show the weakness of the posterior wall of the inguinal canal, and you can see the fascia transversalis, and in Valsalva maneuver, you can see it bulging. And this is the idea of this bulge compressing the nerves that are lying on the posterior wall of the inguinal canal. Then, if you have the means, you can do the MRI to confirm some adductor changes. You can see a secondary cleft sign, which is a sign of the tear of the anterior aponeurosis at the pubic symphysis. You can see some bone marrow edema, iliopsoas injury, or possibly labral tears of the hip. But you have to be aware of incidental findings because it has been proven in the literature that a number of asymptomatic players could have some changes in the MRI. So we don't treat the image, we treat the patients. So why do we do the surgery in patients like this who don't recover? Because the idea behind the surgery is strengthening of the inguinal canal posterior wall and nerve decompression with the surgery or resection if there's too much scar tissue around. So when do we do surgery? It's when they have symptoms more than 2 months, that rehabilitation with experienced groin physiotherapists for at least 4 weeks doesn't give significant results. And ideally, when the patient already has strong core muscles, because if someone has a strong body, you cannot expect to have huge results with strengthening. He's already strong. But if you have someone who is weak, you need to give him more time because surgery won't solve the problem itself. The first surgery was done for an athlete in '67 in, I'm proud to say, in Belgrade, Serbia, by Dr. Nešović, who was a football player himself and had the idea to operate on a fellow football player to do a modified Bassini repair to reinforce the groin area, not to cut the adductors, which was prevalent at that time. And the difference between modified Bassini repair and the Bassini hernia repair is in hernia repair, you open the posterior wall of the inguinal canal completely and then interrupted sutures go through all structures. And here you don't have a hernia, so you just need to pull these muscles more down to the internal oblique and transversus, more down to the inguinal ligament, and reinforce this area because of the bulge that we just mentioned. Nowadays, the best surgery, open surgery, non-mesh for hernias is Scholde's inguinal hernia repair, developed in Canada 50 years ago. And in this surgery, again, you open the posterior wall, but it's a continuous suture in an overlapping fashion, going first the posterior wall, then the second layer, and then the third layer is the muscles with the inguinal ligament, and the fourth layer coming back. So it's a 4-layer continuous suture, no mesh, very good repair. With real hernias, in top-level clinics, they have less than 3% recurrence. In Scholde's Institute, even 1%. So it's a pretty good surgery. Some people do Liechtenstein, which is a mesh, open mesh repair. So just put a mesh in this area, a piece of polypropylene or some other material. Suture it, it's pretty easy to do. Learning curve 5 cases, and this is why a lot of people are using it. Then we can have nowadays endoscopic surgery, where people in 2 different modalities. It's transabdominal, totally extraperitoneal. I will not go into details because it is not important. What is important is that every endoscopic surgery requires a mesh placement in the, coming from behind in the inguinal region. So it is a mesh repair with a smaller incision. And some colleagues, like David Lloyd in England, during this surgery also do a release of the inguinal ligament because he believes that the inguinal ligament pulling on the pubic tubercle is causing the pain. But I would quote the president of the European Hernia Society, Professor Schumpelik, who says that indiscriminate use of biomaterials in every case of hernia at every age disregards some complications that could happen in with this procedure, and that the principal treatment of primary inguinal hernia should be the suture repair in the shoulders technique. And I have to remind you that in these cases, we don't even have a hernia. It is young, healthy population with strong muscles and with no comorbidities, no risk factors. So it's a question, should we use a hernia? So my favorite surgery for athletes is the one developed by Dr. Mushavec from Munich. And I'm happy to say that she is also one of our visiting surgeons here in Aspetar. And it's been proven in different studies that this repair is superior to Bassini and also supports her theory that the posterior wall is compressing the genitofemoral nerve. We have a paper from Turkey that's, they did electromyography of at the cremaster muscle, and they proved that the genital branch of the genitofemoral nerve is affected after surgery, inguinal surgery, and also with people for long-standing hernias. And this is the procedure itself. The difference between the shoulders repair is instead of opening the posterior wall completely, she just opens the small part near the internal ring where the small bulge is, the weakness, the weak spot, instead of going all the way down, and then repairs in a double layer from here, going down and coming back. It's kind of a 4-layer similar to shoulders, but with less tension, and enables patients to come back to the field more quickly. So thank you very much, and we hope that the competition will be solved in the field and with the ball, not by injuries. If you have any questions, I'm happy to answer you with my team. Peter.
Vuckovic, thank you for a great...
Sorry. Just a moment. I apologize. Got carried away. Yeah, we can do the question, but one more thing that we need to do. I was so much involved in the inguinal procedure, so we need to hear Dr. Jules Bull telling something about the adductors. But I'll answer your question, and then and you can ask, and then we'll go with Jill.
Okay.
Yeah.
So very clear, we heard the last 2 days that there's a lot of similarities in epidemiology and the chance to have an injury between football and handball. Now, we all know the epidemiology of groin pain from football, but there's limited data in handball. In your experience, do you think there are similarities to be expected with the new data to be collected? Is it underreported, or you think it's a different thing?
I would say that it is underreported. Probably we didn't study it hard enough, but I would also expect to have less problem with handball players than football players because they have changing directions and all these strains, but they don't have a kicking moment. So we know that groin pain is usually in the sports with sprinting, changing direction, cutting movement, but also kicking. So you have it in rugby, you have it even in American football, and especially in football, what we call soccer. Okay. I apologize once again for
You don't want to speak, but it's nothing, eh?